Hello, everyone. This is Anna Maria, Vice President of Marketing at Cincy. Welcome to today's webinar, which will highlight the latest insight into evaluating the quality and safety standards for virtual care. Key topics will include an introduction to the Joint Commission, context on how virtual care and telehealth is changing healthcare, the role of surveyors, expectations for in-person care versus virtual care, and implications for accreditation. All attendees are muted during today's presentation. We thank you for your presence. If you do have questions, please type your question to the chat room, and at the end of the session, our presenter will actually answer each question one by one. Today, we welcome thought leader Cristina Cordero, PhD, MPH, who will share her insights on this topic. Dr. Cordero is a project director in the Department of Standards and Survey Methods within the Division of Healthcare Quality Evaluation at the Joint Commission. She is focused on standards development projects for the hospital and laboratory accreditation programs. She's developed the Patient-Centered Communication Standards and the Joint Commission monograph called Advancing Effective Communication, Cultural Competence, and the Patient and Family-Centered Care, a roadmap for hospitals. Dr. Cordero has also provided research and technical support to the Joint Commission's Hospitals Language and Culture study. She's a contributing author of One Size Does Not Fit All, Meeting the Healthcare Needs of Diverse Populations. Prior to joining the Joint Commission, Dr. Cordero conducted basic science and public health research at Northwestern University's Feinberg School of Medicine. She's earned her Doctor of Philosophy and her Master of Public Health degrees from Northwestern University in Chicago/Evanston, Illinois. Thank you, Dr. Cordero, for presenting on today's topic.
Thank you so much for the opportunity, and thank you everyone for joining us this afternoon or morning, depending on your time zone. I did want to spend some time today, as Anna Maria mentioned, talking about evaluating the quality and safety of virtual care. I'll go back and forth between saying the terms virtual care and telehealth, because we typically use the term telehealth at the Joint Commission, but they do represent the same type of service. And so just to do a little bit of background on the Joint Commission in general, for those of you who may be less familiar with us and what we do, we are an independent nonprofit organization that accredits and certifies over 21,000 healthcare organizations and programs across the country. We do accreditation in hospitals, as well as clinics, behavioral healthcare programs, nursing care centers, a multitude of different settings. And our vision statement really focuses on all people always experiencing the safest, highest quality, and best value healthcare across all of our different settings. Our accreditation programs are really based on our accreditation requirements, as well as our on-site survey process. So on the slide 3, is a little bit of information about our accreditation requirements. They're really geared towards helping organizations measure, assess, and improve their performance over time. And our standards focus mainly on patient and organizational functions that are essential for providing that safe and high quality care that we're looking to observe in these organizations. We have a number of expectations that are really consistent across programs. So you'll see similar standards and requirements that we would expect to see on the hospital side, as well as in the clinics, in the nursing care centers. So for organizations who are accredited by us in multiple programs, you'll see a unified approach and some consistent expectations across those settings. But of course, we also have program-specific standards that are more geared towards the clinical laboratory setting, for example, that you won't see in some of our other programs. We evaluate compliance with our standards based on a number of different pieces of information that we get when we're on survey. Verbal and written information that's provided to our surveyors as they're moving throughout the organization and talking to leadership and other staff in the organization, as well as on-site observations, things that they're noticing along the way as they move through the organization, and interviews directly with staff and sometimes also with patients from those organizations. We get a good idea of what's going on, how patients are receiving care, what goes on in terms of the processes and the different functions across the setting that we're in. On slide 4, this is a little bit of detail on the on-site survey process in general, and many of you may have experienced this yourselves depending on your role. Our survey process is unannounced. It occurs typically between 18 and 36 months since your previous survey. And that really is so we can observe your organization under normal circumstances. You know, it's not necessarily an announced survey where you know that we're coming so that you can straighten everything up, get everything in order. We really want to see what it's like in your organizations on a day-to-day basis and how you're functioning over time. I mean, I make a joke that I have a 1-year-old at home, and so I don't necessarily like an unannounced visit from my in-laws because I do like that opportunity to get things straightened up and put things away. But, you know, again, the goal is to observe organizations in normal circumstances so we know what's happening over time, and it kind of gives us that opportunity to affirm this expectation of continuous compliance. So this is what we see in that window of time that our surveyors are on site is what we would expect to see at any time throughout your survey cycle. Our tracer methodology is kind of the hallmark of our survey process. It allows us to use real patients and individuals being served by your organizations as a framework for the entire survey. Again, we'll take patient records from individual patients that are actively being treated in your organizations or have previously been discharged within that survey time frame, and we'll use the care that those patients received as a way to weave our way through your organizations to see what departments they went to, what staff they may have interacted with, get a feel for how your policies and procedures work throughout the organization. So it allows us to follow that experience of care as patients are moving in the different settings in the different areas and maybe interacting with different aspects of the setting itself. Our on-site survey process, of course, is our opportunity to evaluate compliance with our standards, but it's also an opportunity for education. And a lot of times our surveyors do have that chance to provide additional information and consultative advice to share some leading practices and some of the experiences that they've had visiting organizations across the country. So that's a little bit about what the Joint Commission does in general. And then I'll switch gears a little bit on the next slide to talk about telehealth and virtual health and how that is changing healthcare. I'm not sure if you guys can see the wonders of PowerPoint animation here that really talks about how telehealth is changing healthcare. What used to be a visit to a brick and mortar facility to get healthcare is now something that patients can do on the go through their phones, through their tablets and computers. They can do this at home, and they can really access this type of care, not all the types of care, but a type of some of the interactions that they would have had in person, they can now do through telehealth and virtual care. On slide 6, we know that the telehealth services and virtual care services are expanding rapidly over the past few years. This is just some data from a recent study from the advisory board stating that 77% of patients want access to virtual care and telehealth. Patients are ready for this, and they're asking for this kind of access. As a mother of an infant, I think that I'd have a much better appreciation for not wanting to pack everything up into the car and to go see a pediatrician if I can get access to a pediatrician in the middle of the night, because I see something that I think might be diaper rash or might be something else, or does my son have an ear infection? I think that my appreciation for having that kind of real-time access is much more heightened now that I have a son than I was before, when I may have had the freedom and the ability to go to a physician's office or go to an urgent care clinic or seek out care and go to those different places physically, where now it's much more convenient to be able to access that care virtually. On the next slide, this again is just some information and data from the American Telemedicine Association's website, just looking at reimbursement. Part of the expansion of telehealth is because patients are asking for this, but also because states are requiring private insurers to provide the same level of reimbursement for telemedicine as they are for patient visits. And what you're seeing here is in the in the orange, telemedicine parity laws are expanding throughout most of the country, and then you'll see a little bit of ongoing legislation also represented in this map. But again, the idea is that we're seeing the shift from the patient side, we're also seeing a shift on the reimbursement side, and then in terms of the provider side, on the next slide, on slide 8, this is just some information about multi-state licensure and the different laws that are being enacted to allow providers to practice across state lines. The Interstate Medical Licensure Compact is more geared towards physicians, and that's a compact that allows physicians to have multi-state licensure across 22 states. There are 2 different nursing licensure compacts. One is 29 states focusing more on RNs and LPNs and vocational nurses. And then the APRN, the Advanced Practice Nurse Compact, is still in progress. They need 10 states to sign on to that compact in order to implement it. And the last time I checked, I think they were at about 3 states that were implementing that, or 3 states that were signed on, and then there were a couple more states that were in progress. And then more recently as well, the Veterans eHealth and Telemedicine Support, the VETS Act of 2017, had some provisions in there that allow VA providers to practice across state lines and kind of address some of the previous barriers to allowing that kind of interstate practice. So on slide 9, what I'm sure more of you has signed on to this webinar to hear more about is how does the Joint Commission evaluate the quality and safety of telehealth and virtual care services? So I'll go through a few things about how our program is set up and how what kinds of issues we talk about on survey, and then we'll talk a little bit about some of our other current initiatives. So on slide 10, just in terms of evaluating telehealth and virtual care, the way that we approach this at the Joint Commission, we have, of course, our accreditation requirements. We have 2 programs that address organizations that are providing only telehealth or virtual care services. Our ambulatory healthcare program has different settings within what we call telehealth surgical or telehealth non-surgical services, and that can accredit organizations that are providing primarily telehealth services. Our behavioral healthcare program also, we refer to it as technology-based services, but again, this addresses organizations that are primarily providing telebehavioral services. Those programs also address other programs and other types of services within ambulatory and within behavioral, but I just wanted to point out that for organizations that are primarily providing telehealth services, if they fit into our ambulatory program or our behavioral program, we can do accreditation just for organizations doing mostly telehealth. Our other programs, critical access hospitals, home care hospital, laboratories, and nursing care centers, we have a mixture of organizations within those programs that may be incorporating some telehealth into what they're currently doing. So they're doing kind of a hybrid of in-person care as well as providing some telehealth services to their patients. And that is something that we are incorporating into our current accreditation of those programs. So again, this is for that mixture of services. When we go out for a hospital survey, for example, if your hospital is providing in-person care as a hospital and then also providing some telehealth services, our current survey process and our current standards can encompass the quality and safety of both types of those services. And I'll talk a little bit about those models in a few slides. But just to give you a general overview, we have some programs that are specific for dedicated telehealth organizations, and then we can still evaluate the quality and safety of telehealth through our current program. On the next slide, in terms of our current telehealth and virtual care initiatives, we know that as customers are adding and expanding telehealth and virtual care services into new settings and specialties, for example, tele-ICU, we have some organizations that are starting to incorporate more of the direct-to-patient, direct-to-consumer type telehealth service. We have wanted to ramp up our efforts to look at telehealth and make sure that our standards and survey process could apply to these new types and expanded services. So a couple of projects that we're doing right now on slide 11. We have surveyor guidance for all of our programs that we are releasing in the next month or two, and I'll talk a little bit about that. So we developed some additional information, background, recommendations for our surveyors to address telehealth issues on site. We also incorporated some of the direct-to-patient, direct-to-consumer type telehealth interactions into our survey process. For those of you that may have been following our progress and some of our new standards over time, we did do a project about a year or two ago to look at incorporating direct-to-patient, direct-to-consumer standards into our ambulatory and hospital programs. We ended up doing some research and development work to that end, and then ended up having some different varying feedback from our public comment period. So we decided to not release those standards, and instead we incorporated some of those same safety and quality issues into our survey process. So we can still evaluate direct-to-patient, direct-to-consumer type services, but we did not release new requirements that were specific to those services. We did have some recent revisions to the applicability grids for our ambulatory program, and I'll talk a little bit about that, as well as some in-process revisions focused on credentialing and privileging. So on slide 12, just to give you an overview of our surveyor guidance initiative, this is some additional information that we released to our surveyors that is really applicable to all of our accreditation and our certification programs. because we're seeing this expansion of telehealth services, not just on the accreditation side, but also in some of our disease-specific care certification programs, particularly around comprehensive stroke centers, acute stroke-ready hospitals, and some of those other programs. So we wanted to make sure that all of our surveyors and our reviewers, all of our on-site staff was getting the same type of guidance about how to approach telehealth services that they are encountering in these organizations, as well as how to apply our standards and what standards they should be thinking about. So we did provide an overview of the different telehealth and virtual care models to the surveyors, including that direct-to-patient, direct-to-consumer interaction that people are starting to see more of these days. And then we also provided some recommendations for patient tracers, patients that you might want to consider pulling the charts for those patients to follow the care that they're receiving through these organizations and to see how telehealth was incorporated into their care. So we have recommendations on picking different patients by age, different populations, as well as the level of familiarity that the patients may have with telehealth. So depending on the service that we're looking at, we want to make sure that, if they're picking a patient that's using telehealth for the first time, for example, in a home care setting, there might be some aspects of patient education and patient orientation that you would want to find out about, and then maybe patients who have been using telehealth and going through their interactions via virtual care service more frequently, patients that are kind of familiar with that technology and kind of see what kind of interactions they're having and what the organization is doing to make sure that they understand how the technology works or what other aspects of their care, or maybe it's a seamless transition. But we just want to kind of get a feel for how patients are using telehealth services. And then, of course, we have a number of issues to explore, sample questions they can ask the organizations that we put in, so the surveyors have some prompts for how to incorporate their evaluation telehealth services into the survey process that they're already doing for in-person care. So the first question on slide 12, the first question that we always want to ask when our surveyors are on site trying to figure out how to apply our standards and survey process to telehealth is, how is the organization itself incorporating telehealth or virtual care services? And depending on how those services are incorporated will kind of give us an idea of what kinds of questions we should be asking and which standards would apply in those situations. So on slide 13 rather, this is scenario 1. So I apologize for any of those of you who have a little bit more experience making PowerPoint graphics. These are just my standard stick people that I draw on marker boards and on pieces of paper throughout all the meetings that I go to in the Joint Commission. Scenario 1 really focuses on organizations that are receiving telehealth or virtual care services through a contractual agreement with another organization. So just to kind of go through this scenario, on the left side of this slide, organization A is where the patient is. So for those of you that also follow some of the CMS documentation out there and the CMS requirements, that they refer to that as the originating site where the patient is. I typically just refer to that as the patient site because it's just easier for me to understand that. So the patient in this scenario is at organization A. Organization A is contracting their virtual care services from another organization. Sometimes that can be a larger organization, an academic medical center contracting services out to a smaller rural facility, for example, a hospital contracting with a clinic. Examples here would be something like telestroke services or telepathology services, where you'll have an organization that needs to receive those services from another organization because they just don't have those resources at organization A. Again, in this scenario, the patient is on one side at organization A at the originating site. The providers are at the distant site at organization B. Some of the issues that could come up at an organization set up like this, when our surveyors go to organization A to see that they're receiving services from another organization on contract, we would ask to see the contract. We would want to know what's in the contractual agreement for those telehealth services that are being provided. What are your expectations as the patient side of that? What kinds of turnaround times do you expect to see? If they're images, what kinds of resolution do you expect to have for some of that information being transferred back and forth between those organizations? We would want to know what the education and training would be for the staff at both sides at organization A in terms of accessing the telehealth services. If, for example, there are, peripheral, different, you have a camera, you have other pieces of equipment, how you would arrange those things, how you would, monitor that the connection is working, those kinds of things. So you would know what the staff that is receiving those telehealth services, what kind of training that they receive to kind of access the services, use those services. Any maintenance of telehealth equipment that's being used in the organization, if that equipment is owned by organization A, or if they're contracting it or renting it from organization B, again, depending on the service, those issues may come into play. Sometimes patient consent to the use of telehealth services is also something that would come up. If there are patient consents to use telehealth services, how is that documented? How does the patient ask questions about those issues? Interviewing staff and patients, how you are identifying patients that are receiving telehealth services. If people are being monitored, for example, in a EICU situation, how is that information being transferred back and forth? And then if the telehealth services are being reflected in the medical record, how is that being reflected? Where is that being reflected? One of the other issues that would come up with organizations that are contracting in telehealth services would be credentialing and privileging of the telehealth providers. And so again, what is that process for credentialing and privileging of the providers from the organization that you're contracting with? Taking a look at any state laws around licensure, and then any competency issues around trying to verify qualifications of the contracted providers, and again, looking at licensure there as well. So that's one example, and we are seeing more of that, I would say, from the organizations that we are surveying, because more organizations are starting to contract in telehealth services from other providers. The next slide, slide 14, is the opposite of that equation, the reverse of that equation, where you have an organization that is providing telehealth or virtual services to another organization through a contract. So this would be organization B. Now, this is sort of your potentially a teleradiology organization, for example, or a larger, again, academic medical center providing services via contract to a smaller organization or an organization in a rural area, for example. So again, this organization B on the left side of slide 14, your provider distance site is that part of it. Teleradiology, tele-ICU are the examples we have listed here. That would be services that could be provided to organization A, which is where the patient is. So again, there's some similar things we would look at in that kind of a scenario. Again, we still want to look at the contract for what your organization would be providing to another organization. So what are the expectations that you have for how that connection is, how the interaction is, any equipment that you're loaning out to that organization, any kind of expectations you have about how the patient is presented to you, that kind of a thing. Again, looking at your credentialing and privileging of your individuals that are on your staff, that your telehealth providers, looking at education or training that they've received to provide virtual care services, licensure qualifications, and any process to assess staff competence. One of the other aspects of this kind of contractual relationship is also what kind of feedback do you get as the telehealth provider organization? What kind of feedback are you getting from the organizations that you're contracting with? If there's any potential adverse events or other issues that they may have, other questions about your providers, what kind of feedback is that, and how do you incorporate that into your ongoing assessment of your providers? Again, when you think about potential tracer scenarios for this, we would be asking questions about, what patients are you providing services to? And then again, how does that patient, how are you accessing the patient records? How are you getting information about that patient? How are the patients consenting to the use of telehealth services? And again, interviewing staff on your side of the interaction to ask about how they're trained and to provide the services that you're providing. Scenario 3 on the next slide, this is slide 15. This is when an organization is using its own practitioners to provide virtual care services directly to patients at home. So this is another thing, again, that we're starting to see more of, where you've got providers in an organization. There may not always be at organization C. Some organizations, I know their providers are also working remote, and they're providing services directly to patients at home. So this would be an example of remote patient monitoring in the home care setting, virtual urgent care visits, or some of the direct-to-consumer, direct-to-patient type behavioral services, some of the other like I said, virtual urgent care, it's already on here, those types of services where patients are at home and accessing telehealth through their computers or tablets or phones. So this would be an example of me accessing a pediatrician in the middle of the night because I'm a first-time parent and I'm not quite sure what's happening with my son. And I will say that I have access services in this way, and they've worked out fantastic. So again, this type of organization, again, we could accredit for a number of different things. We're starting to see a little bit more of organizations that are providing 100% of their care in this way. And we're trying to, again, adapt our current survey process and our standards to address this. And so some of the issues that could come up here would be, again, looking at the credentialing of and the competence of the telehealth providers themselves. How are you looking at qualifications and licensure? How are you matching your providers to the patients that are at home and based on their location and states and licensure issues? Again, looking at education and training of your providers, staff competence issues in general. And then again, we're looking at, depending on the type of service, remote patient monitoring, for example, there could be some equipment issues. So we would want to know how are patients receiving that equipment, being trained to use that equipment, if it's being returned to the organization, how is all of that? How is that process managed? Looking at how you determine eligibility for patients that would be receiving services, if there's any, what your scope of services are, and how you would handle patients that you can't treat if, for example, in a virtual or urgent care situation, if there is a level of care that they require that kind of is outside of the scope of the services that you provide, what is your process to send those patients to another area or refer them to care through another source? Let's see if there's anything else. Most of this is also kind of consent for the use of services. And then again, staff training issues in terms of how are they providing services and what kind of information have they received to handle different scenarios. Scenario 4 on slide 16, this we don't see as frequently, but we know that it does come up particularly around some telestroke and sometimes with teleradiology. This is where organizations are using their own practitioners to provide virtual care services, and they happen to be at home, and the patients are in the organization. So this one, again, we don't see as frequently. This is more on the hospital side. We might see something like this, where you've got a provider at home, maybe off hours or doing something where they're working remotely, but their patients are still within the healthcare organization. So kind of the reverse of scenario 3. Organization D is, again, that's sort of where the patient is and the provider is in the home setting. So again, telestroke, sometimes you'll have neurologists that will use telehealth to check in on patients and to provide some additional consultation. So again, that's sometimes, depending on the type of service it is, could be some issues around staff qualifications to provide those services, as well as some of the equipment, information management, access to patient records from home. Some of those issues may come up there. Slide 17 is more of an overview of our recent changes to the applicability grid in our ambulatory care program. So for those of you who are providing telehealth services that are even, teleradiology would be a good example of that, some virtual urgent care that are part of our ambulatory program, either telehealth surgical or telehealth non-surgical settings. We did make some recent changes to the applicability of the standards for those programs. And what happened, I know the slide is littered with different standards, names and numbers. And if you're not in our standards department, most of us memorized most of these numbers. So this may just be more for reference for those of you who have access to our manuals. But what the goal of that project is to make sure that the standards that we're looking at on an in-person on-site survey for a telehealth organization makes sense. So there were certain things in here that are represented around hand hygiene, certain things around emergency management, and doing different things within an organization that may not have patients in-house, because a teleradiology organization, for example, would not have patients in-house. Sometimes the providers are not in the organization either. So there are certain things that we had applicable to those organizations that our surveyors were looking for that may not make sense because they don't have patients in the area. So we changed the applicability and took away some of those standards to streamline that accreditation process and to make that on-site survey process more relevant to the type of services being provided. So this is just a screenshot of the requirements that were no longer applicable, just to show that we did make an effort to take the applicability away from requirements that we didn't think were relevant to that particular setting. The next slide, slide 18, is a project that's still in progress, but we did also propose some revisions to our contracted services standards for a couple of different programs, focused mainly on streamlining the requirements for contracted services, and it addresses the credentialing and privileging of telehealth providers. We had some proposal to delete the medical staff requirements that were addressing telemedicine in our hospital and critical access hospital requirements in our manuals, and we did a six-week field review between January and March of this year to get some public comment and feedback about those proposed revisions to see if that was something that the field was ready for or was supportive of, and to make sure that we could take a look at what we could, some opportunities to streamline those requirements and see if we can make it more straightforward, because we're seeing more contracted services, particularly contracted telehealth services. So that project, like I said, is still in progress. So I don't have an update other than just to let you know that it is in progress. We did get feedback from the field and we have analyzed that feedback, but I double checked with the project team on that project and they're still making some decisions about what to move forward and the timeline for that. So I can't give you any more detail on that, and I don't have an implementation date, but that is in progress because we did take a look at that process, because we know as more of our accredited organizations are starting to contract in telehealth services from other organizations, there were some questions that we were getting about the credentialing and privileging component of that. So in summary, I just wanted to summarize on slide 19. Again, our approach to surveying for telehealth is really that the same standard of care applies in person or via telehealth or virtual. So a lot of the requirements that we would use and a lot of the things that I mentioned in terms of what we would look at on survey, many of the standards that apply to those issues are the same that we would look for in an in-person interaction. So we don't have specific standards that say telehealth. A lot of what I said, again, we're talking about credentialing and privileging, equipment, consent. Those are the same standards and requirements that we would have if this care was being provided in person versus virtually, because we really don't, we want that same level of quality and safety that you would have in person. Just because you're using care through a screen doesn't change the way that we would, what we would expect to see. We would change slightly the way that we apply those requirements and the kinds of questions we would ask, which is what I went over with the diagrams, but the requirements themselves are largely the same. We have very few standards in the Joint Commission manuals across all programs that use the terms telehealth or telemedicine. For those of you, again, who have access to that, most of those requirements are around credentialing and privileging, but a lot of the standards that we would use and the issues that I referenced in the presentation, again, are really about the same requirements that we would expect to see. So the same type of preparation that you would do for a survey for in person, we would expect to see many of those same things on the virtual side. I mentioned the applicability grids are where you would identify which standards would apply to organizations that are providing primarily telehealth services in our ambulatory and our behavioral healthcare programs. So for those types of organizations, you would get a subset of the standards in our ambulatory and behavioral manuals. And so again, we just made some recent revisions to that to actually make that set of standards smaller for the ambulatory program. But that's where you would access those standards as well. I mentioned we put together some surveyor guidance for our on-site staff, and that includes a lot of the diagrams that I talked about, some of the input and the prompts and the questions that we went over. That also allows us to include that direct-to-patient, direct-to-consumer type interaction. And then I just mentioned we have the revisions to our applicability for the ambulatory care program. And again, that decreases the number of standards that they're looking at, and our proposed revisions. And I hope to have some updates on that project in the next few months. So I know that was a lot of information, but I know that they've been tracking questions as well. So I can turn it back over to Ana Maria for some Q&A.
Thank you, Dr. Cordero, for presenting on today's topic regarding the quality and safety standards for virtual care and telehealth. Please feel free to type in any questions you may have on what Dr. Cordero talked about today, or you can reach out to Cinzy.com and we'll make sure that you're in touch with her in the future. In the meantime, I'll give a little overview about Cinzy. Today's webinar was hosted by Cinzy. We are a technology company dedicated to providing better ways for you to manage and engage colleagues, patients, and members simply and efficiently. Synzi goes beyond traditional telehealth with its award-winning virtual care communication platform for providers to use to engage their colleagues and their patients and members with video, secure messaging, and/or email. The platform allows virtual visits and virtual consults to be conducted on any smartphone, tablet, or computer, and on any level of cellular or Wi-Fi connectivity. Thank you, everyone, for your time and interest. A special thank you again to Dr. Cordero for all of her time and energy in developing and presenting this webinar today. We greatly appreciate it here at Synzi. This concludes our presentation today. We will send a recording of this presentation to all who have attended shortly. Take care.